Good morning out there, everyone. I will give folks a few minutes to jump on, but we are super excited to have you all here to go and really kick off Black Maternal Health Month or Week with our Born in Nebraska Lunch and Learn. So while we're waiting for folks to get on, get your water. I got mine right here. Grab a little snack. We're going to have a great conversation. So we'll give folks about one more minute to jump on, and then we are going to dive right in. All right. So, again, welcome, welcome, welcome. We're super excited to have you with us as we kick off Black Maternal Health Week. It is a national week of awareness and celebration and action as we think about the experiences of Black birthing people and what it is that we need to be able to thrive. It is a national week, so there are tons and tons and tons of events from national organizations happening. And here in Nebraska, IB Black Girl is leading some of the local initiatives and activities and sessions. So I am Ashley Spivey. I am the director of IB Black Girl. And super excited to be here with you today. So for those who have not heard of IB Black Girl, and this is your first time tuning in, IB Black Girl is a reproductive justice organization. We are a collective that works on behalf of and for Black women, femmes, and girls to actualize and reach our full potential. We do that in a number of ways. And we are here today because of our birth justice work. So really thinking about what does it look like for us through our birthing experience when we choose to get pregnant, when we choose to have that pregnancy, and then parent. What is our experience? What do we want that to look like? How can we actually thrive and decide, again, our trajectory? And so as we were thinking about part of that work, it only made sense for us to invite key partners through Department of Health and Human Services around that conversation, right? Like they have an important role in thinking about birth justice work in our state. And I'm super excited to have two folks here from Department of Health and Human Services to talk about the data. Data can be not accessible. Like, I'm not a data person. I tell that to everyone, but I understand its importance, right? And so we are going to hear from two people who manage and support two data sets and reports around the numbers of infants and birthing people um, from our experiences, especially when we talk about, are we dying when we give birth? Are our children dying postpartum? And so it's an important conversation. Again, sometimes it's not as accessible. So I'm really excited to be able to have them here, help us unpack what the data means, the recommendations from these reports, and then again, how we can continue to move the needle. So with that, I am done talking. I will drop some links in the chat, but I'm excited to introduce first Celeste, who is the maternal and child health epidemiologist at Department of Health and Human Services, to look at the Maternal Mortality Review Committee report and all the information that comes from that. Hey, Celeste.
Hey, Ashley. Thanks so much.
Yeah, I'm super excited you're here. So we are going to start with Celeste, and then we will jump to our next presenter, followed by a Q&A. So Celeste, if you want to get started, share your screen, and you can jump right in.
Sounds great. Thank you. So as I get the screen up, I will just say thanks, Ashley, for introducing me. Again, I'm Celeste Ilian, and I'm a maternal and child health epidemiologist with DHHS. And a big part of my job is coordinating the Maternal Mortality Review Committee, or MMRC, as you may have heard. And so today I'm just going to share with you a little bit of information about what exactly the MMRC is, what we do, and then some data that came out, we were able to release last year in a report. So we'll just go through some slides here. We'll first give you some definitions about maternal mortality because there are different definitions pretty much anywhere you look. So I'll tell you kind of the definitions we use, give you some history about how the MMRC kind of came to be, and then start talking about the data. All right, so as I mentioned, different agencies and organizations have different definitions of maternal mortality. And those definitions are really used to track and analyze deaths across the state, nation, world. And so when we typically talk about maternal mortality, I'm talking about death of a woman during pregnancy or within 1 year of the end of a pregnancy. And that's kind of the CDC definition. So that's what we use as well at the state. And if we're using that definition, we can say that approximately 700 people die every year in the United States from maternal mortality. So that's that big box on the left. And then if you look at the other two boxes within maternal mortality, there are two kind of subcategories. So the first is pregnancy associated deaths and then pregnancy related deaths. And pregnancy associated deaths, that middle box, they include all maternal deaths within that 1 year time frame, no matter the cause. And then pregnancy related deaths include only deaths that are specifically related to a pregnancy complication. So, an example, a pregnancy associated death can include something like a car crash. A pregnant person happens to be in a car crash and they die, but the crash had nothing to do with their pregnancy. Now, it still occurred within 1 year of their pregnancy. They were pregnant at the time, so that would be a pregnancy associated death, but not a pregnancy related death. An example of specifically a pregnancy related death would be, say, like a hemorrhage during labor that causes a death. That's specific to a pregnancy complication. If that person wasn't pregnant, they wouldn't have died because that wouldn't have been a thing. So, those are kind of the differences between pregnancy associated and pregnancy related. And I'll use those two terms throughout the presentation. So, just keep that in mind. So, a little history about the Nebraska Maternal Mortality Review Committee, or MMRC. Sometimes people ask me, when was the MMRC started? And I'm like, well, what do you mean? Because in 2013, the maternal deaths were added to the Child Death Review Team scope by a state statute. And then in 2014, maternal reviews began based on that statutory authority. At the time, the Nebraska Medical Association really led that effort, and there was a smaller committee charged with reviewing maternal deaths. Then in 2018, there was really this big national push to standardize reviews across the United States so that we had kind of comparable results. And that push really spurred this change in how maternal reviews were done in Nebraska, where they were reorganized under like a subcommittee of the child death review team. So now it's the child and maternal review team. Um, and the reviews that are using that standardized process began in 2019. So I, I think technically MMRC started in 2014 if we're looking at this kind of short timeline. And now that we're using that standardized review, we have a specific form that we complete, and the committee is really a multidisciplinary group that reviews abstracted cases of every single maternal death in Nebraska. So we review all pregnancy associated and pregnancy related cases. We have medical professionals, doctors, nurses, etc., on our committee. We've got epidemiologists and other public health professionals, representatives from domestic and sexual violence prevention groups, insurance, tribal representatives, doulas, just kind of a really broad array of folks who have interaction with pregnant and postpartum people. And we continue to add new members in a really systematic way so that we're trying to make sure we have a broad representation as we move forward. So the process of the MMRC is kind of this 5-step process. And I know this is like a lot of text, so whatever, don't read it, but we'll just kind of go through what happens. So first, cases are identified. Um, we use death certificates, birth certificates, and fetal death certificates to identify maternal deaths. And then we request records. So the MMRC receives records from like obviously medical records, birth and death certificate, um, and fetal death certificate as well. And then law enforcement reports, coroner reports, and autopsy reports, and then sometimes more specific reports depending on the case. All of those records are abstracted by our nurse abstractor, and she creates a summary of the person's life and death, really. And then the MMRC convenes quarterly to review those abstracts. And there's 6 things that we're trying to determine. So, was the death pregnancy related, as we talked about a little bit ago? What was the true cause of death? Was the death preventable? What were the contributing factors to that death? What are some recommendations we can make around those critical contributing factors? And then what is the anticipated impact if we were able to implement all of those recommendations? Finally, after all of those reviews are complete, the data are compiled and we can create reports like the one that just came out last year. That was our very first report. So we can get into the results. I know we're here for the data, right? So we'll move right into that. So our report that came out last year really focuses on years 2014 through 2018, so deaths that occurred in those years. And in that 5-year period, 49 pregnancy associated deaths were identified. 18 of them were determined to be pregnancy related. And so the pregnancy associated mortality ratio, I know we're getting into like big words, right? But pregnancy associated mortality ratio for that 5-year period was 37.29 deaths per 100,000 live births. You may also hear people talk about the pregnancy related deaths, which, as we talked about earlier, there's really a big difference between pregnancy associated and pregnancy related numbers. But the pregnancy related mortality rate for Nebraska was 13.7 deaths per 100,000 live births, and the national rate that's similar is 19 per 100,000. So we were slightly below the national average there. And as you can see, we average about 10 maternal deaths per year. So, because of that, we have a fairly small Nebraska population and also a very small, thankfully, number of maternal deaths. So it's really, um, it does provide kind of a difficult situation for trying to analyze the data, because when we break down numbers that are so small, um, one, we're not able to release a lot of small numbers because we want to keep people's confidentiality. But also, if we're calculating rates and ratios with those small numbers, we can see that like one death could make it look as if the numbers were changing very rapidly, when really it's just because of small numbers. So just keep that in mind as we're going through this data. This is like the best we can do with our small numbers, which is both a good and a bad problem. You know, we don't want a lot of people to die, but obviously it also makes it a little bit challenging to present data. So here's a really big, busy table with a bunch of numbers, and I'll let you kind of like your eyes view what you want to see here. I know some people are interested in different things, but I'll kind of give you some of the highlights as I see them. So more than 8 in 10 maternal deaths in Nebraska were among white women. However, when comparing to the population sizes, we can see that white and non-white women died at nearly the same rate. So you can see the ratio per 100,000 live births for race is 41.62 in white and 40.78 in all other races. We can also see for age. So women aged 25 to 29 had the lowest pregnancy associated mortality rate of all the age groups. And then women aged 35 and older had the highest. And when we compare those, women aged 35 and older were more than twice as likely to die within a year of pregnancy compared to those in the 25-29 age group. We can also see that women with public insurance at their baby's birth were more than 2.5 times more likely to die compared with women with private insurance for delivery. But it's also important to say that that doesn't mean one insurance is better than the other or one type of payer is better than the other. It's just that likely speaks to the fact that there are other risk factors for folks who had certain type of insurance. Okay, so timing, manner of death, and preventability. You can see here that from 2014 to 2018, almost 60% of Nebraska's pregnancy associated deaths were due to medical causes, and then an additional 10 each were due to motor vehicle crashes and other injuries, whether they be unintentional or intentional, such as homicide or suicide. And most pregnancy associated deaths occurred more than a month after pregnancy ended. In fact, 59% died more than a month after the end of a pregnancy. And also, we were able to determine that 75% of those deaths were preventable. The MMRC is really tasked with determining the factors that may have contributed to the maternal death. And there were over 20 contributing factors identified by the committee for these 5-year period. A few of them are listed above, and as you read through them, you can really see that they're wide reaching and they really affect all areas of a person's life. It's not just one thing, it's really a multitude. You can see on this list, and this is just 9 of the 20. So, lack of access or financial resources, continuity of care, um, mental health conditions, violence, social support. I mean, these are all very different parts of someone's life. These factors, these 9 factors, and then all of the others as well, are used to create the MMRC recommendations, which we'll go into on the next slide. So the MMRC continues to grow and develop in the way recommendations are constructed. Right now, they've identified over 100 recommendations. However, a lot of them are very similar. So actually, in the next couple of weeks, we're getting together to really hone in on these recommendations and come up with a a good list that we can present in the future. So I just put a sampling up here. Obviously, I'm not going to show you 100 recommendations, but here's a sampling, and you can kind of see that there are some themes in a general sense that like revolve around the need for continued screening, assessment, referral, and overall clinical coordination. And then there's also some themes around a medical home establishment, um, making sure people have a place to go and that there's wraparound services as well. And we know that there are a lot of agencies and organizations throughout the state that are working on all of these things, but the need for continued coordination and like agencies talking together and working together for the best possible outcome is really needed. So, what are our next steps? Well, maternal health affects not just individuals, but really maternal health affects families and communities in general. So, the health of birthing people should really be prioritized at a local, state, and federal level to ensure happy, healthy, prosperous families. We're starting to see this. We're seeing lots of pushes, especially at the federal level, for um, more resources to be focused toward mental health, maternal health, all of the things, which is wonderful. So we want to continue to see that. And also, I just want to say, I was able to share with you just a few pieces of information, few pieces of data, which is a huge first step for us. But we know there are gaps and limitations to the data presented. The fact that I had to say white births and all other races combined, that doesn't give a huge like picture of what's going on for specific races within the state, and the same for all of the other categories as well. But with the small numbers, it's kind of like we have to do it what we can. So we know there are limitations to the data presented, but we also want to be able to share as much as possible so that agencies, organizations, people can make the best decisions for them and their families. So if you want to read the full report, I've got the link here, but you can also just search MMRC Nebraska in a search engine, and it'll probably want be like the top link that you see there as well. So here's also my contact information, my email and phone number. If you ever need to get in touch, have questions about this kind of data, or want to work together on something. So thank you.
Thank you, Celeste. Once I get the next presenter up, I will drop the link to the report in the chat so then folks can access it. But really appreciate you naming some of the limitations, going over the data, and then we'll have a chance to dig in and ask questions. So again, after our next presenter, we will definitely have a Q&A and just dialogue about what are the opportunities here, especially as we think about centering Black birthing people in the conversation. So next up, I would like to introduce Jessica, who is the Pregnant Risk Assessment Monitoring System Coordinator, or PRAMS, as some of us have heard, to really talk about that report, the implications, and what does the data say?
Yes, hello. Thank you for inviting me, and I'm excited to share the data for this group. Okay, let me share my screen. Okay, awesome. Here we go. So again, my name is Jessica Sieberger. I'm the PRAMS Program Manager, so Pregnancy Risk Assessment Monitoring System, and I will be sharing today data from our 2019 annual report with a few 2020 pieces. We just got our 2020 data back at the end of last year, and so we're working on getting that into a report and releasing that. So this data, I'll talk about how it compares to the 2020 data. PRAMS is a survey about maternal health, behaviors, and experiences during and after pregnancy. This is the cover of our survey, and we send it out to women and birthing people who have had a recent birth in the last 2 to 6 months. My goal today is to describe PRAMS and its goals, review selected maternal child health data for Nebraska, identify areas in need of action to improve health, and share PRAMS resources. So PRAMS is overseen by the CDC, and oh yeah, you can see my mouse. Awesome. Okay, so most states and jurisdictions in the United States, including the District of Columbia, New York City, and some territories, do participate in PRAMS, and PRAMS represents about 81% of U.S. live births. Nebraska has been participating in PRAMS since 1999, and we have data from 2000 forward. Our goals are to improve the health of mothers and infants in Nebraska and reduce adverse birth outcomes. We do that through data collection, surveillance, and kind of working with partners to share data and advocate for programs and policies that will improve the health of birthing people in Nebraska. We survey 10% of all births annually, and that comes out to about 2,500 births annually in Nebraska. We collect data on an ongoing basis. So as women have births, they are sampled 2 to 6 months after they have a birth, and then we compile the data for a year of births. So people who had babies in 2019 from January all the way to December are sampled when their babies are 2 to 6 months, and then we compile that data into a year of data. PRAMS samples via mail and telephone, and so we send surveys out to birthing people after they have a baby, and then if they do not respond to the survey, we'll follow up via telephone. And we collect data from that 2 to 6 month period up until the baby is 9 months old, just because people have sensitive experiences during that time, and we want to limit recall bias. So we end data collection at 9 months. Okay, so this is a slide with data on our response rate over time. So here you want to look at the overall weighted response rate. And so you can see it's changed over time, goes up and down. And then below that is the CDC required response rate. So we survey, 10% of births in Nebraska annually. And then based on the percent that respond and based on the percent that respond nationally, the CDC sets a required response rate threshold in order for the data to be generalizable to the state and useful. And they compare PRAMS data to birth certificate data and see if there is bias as far as who responded, and use that to estimate what the required response rate threshold is. So PRAMS samples, we stratify our sample. So we kind of organize our sample based on race and ethnicity. And we have these 5 different race ethnicity categories here. And you can see over time the response rate varies. And the African American or Black population hasn't met the CDC required response rate threshold in the last 5 years. And going back before that, it was also kind of hit or miss in the past. And so we cannot at this time release Black data as a standalone data piece. And so it has to be kind of released as race ethnicity estimates. And so that's an opportunity where more work is needed to do things, to make change in order to help increase the response rate for that group. Okay. And lastly, when mothers don't respond, the estimates become biased. So if we are only getting male responses, then it's likely that the demographics for those male responses are different than the general demographic. And if we have under 50%, it's likely that there's something different between people that do and do not respond. And so that biases the estimates. Okay. PRAMS covers data on a variety of topics. We survey people before, during, and after. We survey people after pregnancy about experiences before, during, and after pregnancy, including topics like maternal behavioral health, infant health, childbirth, delivery, etc. And data can be requested through DHHS public records. So there's the email address here. If you send something to me, my email address is at the end of this. I can forward it to the public records request email, and together we can work to get any data that you'd be interested in. In 2016, we started phase 8, and in 2018, we added a disability supplement, and then in 2020, we added a COVID-19 supplement, COVID-19 impact supplement. And in 2021, we added a COVID-19 vaccine supplement. So we have this general clump of data, these pieces of data since 2016, and then the supplemental data for a time period after that. Okay. So again, today's data is primarily from 2019 with a few pieces of data from 2020. That data is available, and I'm working to finalize the 2020 report. The tables are already made for 2019, so that's what I'm presenting. It's easiest, and it's out there on the internet for you to access if you're interested. And the population under review, the population we're looking at is postpartum people with a recent live birth. Again, this data is generalizable to all Nebraska residents who have had a live birth in that specific year, so in 2019 or 2020. And PRAMS is kind of spurred to use data to impact action. And so each year we have to report to the CDC on 2 examples of ways that we have taken data and created action from it. And so in the past, those have been things like supporting breastfeeding initiatives or identifying trends in prematurity and working with partners to improve or decrease prematurity, working on fact sheets, which I can talk a little bit about at the end for data, etc. And doing these data presentations is one way that we share data, but it's not enough. Like, we need more action than just disseminating the data. Okay, moving into the data itself. How am I doing at time? Good. Okay. So first, we've got demographics of the people that we survey. So let's say 60% of people aged 25 to 34 had a birth in 2019. And so you can see the data kind of falls down, or like the numbers fall down from there. So 18% were 20 to 24, 13% were 35 to 39, and then it kind of goes out from there. So the majority of people that had a birth in 2019, again, 25 to 34. Like I said earlier, PRAMS samples its data using 5 race ethnicity categories. So if a person identifies as Hispanic, we take them and separate them into their own race ethnicity group. And then from there, if they identify as Native American or Black or White or Asian Pacific Islander, then they get stratified into those other categories. And so you can see here how the demographics for birthing people in Nebraska in 2019 was distributed. So most women, people that had births in 2019 identified as white, followed by Hispanic, followed by Black, Asian Pacific Islander, and then Native American. And so this PRAMS measurement is something that drives our sampling, and this is the comparison to general birth certificate measurement. So you can see the Hispanic number comes over here and becomes the Hispanic population. But then the other race categories are compiled in a slightly different way than this variable set. So I just share that as a way to kind of reflect on how PRAMS measurement compares to how we think about race and ethnicity as separate categories and generally. Okay. So next into specific health topics, we have health insurance coverage. So I present these two for comparison. So the top one looks at health insurance for delivery. You can see, and I think this is the first one. Well, we've got some here too. Let me back up a little bit and talk about the 95% confidence limit. So PRAMS is a survey, so it's an estimate. And when we create estimates, we have the number that we the estimate, and then we have the range that is dependent on the size of each cell, basically. So when there are more respondents, the estimates can be smaller, and when there are fewer respondents, the estimates can be a little bit bigger. Maybe not in this specific case, but that's generally the way it is. So we've got 59.2% of people that had a birth in 2019 that identified as having private or other insurance, and that true number could range from 56.1 to 62.4%. Okay, so all that to say, contrasting that with health insurance after delivery, so postpartum. So here you can see that number drops a bunch from 39 to 22%, and then the percentage that have no insurance increases a bunch to 14.1%. So in 2020, this data is presented slightly differently, but comparable. So we've got postpartum insurance only comparing 2019 with 2020, and you can see Medicaid or Indian Health Services jumps up a bunch in 2020, and no insurance drops a bunch in 2020. So in October, Medicaid expansion took place, and so we're assuming that this change is related to that. Okay. Moving on to another health topic, we have vaccinations. So this one looks at flu shot during and before pregnancy, and then the Tdap shot during pregnancy. And these numbers are 2019, and 2020 is very similar with a slight dip, but not a significant dip. And these vaccination numbers have trended upward in the last 6 or 7 years. And so increasingly more birthing people are receiving vaccinations before or during their pregnancy. Next, we've got chronic health conditions. So the top table looks at health conditions prior to pregnancy: diabetes, hypertension, depression, and then not having any of those. So you can see 80% of birthing people identified as having zero chronic health conditions prior to pregnancy. And then this is during pregnancy. So gestational diabetes, this number is much higher than 1.6%. High blood pressure, preeclampsia or eclampsia, depression increases, but not as dramatically as the other two indicators of chronic health conditions. And then this did not have any of the chronic health conditions is lower. Oh, okay, here we go. So next we've got depression and anxiety. The phase 8 survey for PRAMS only includes measures about depression. It does not include measures about anxiety. In 2022, so this summer, we will be revising the PRAMS survey and hope to include a question about anxiety, or two or more, multiple questions. So hopefully that will change. But I wanted to present this in a slightly different format because I think it's useful to see how it's changing over time just by looking at the numbers increasing. And so green is before pregnancy. And so you can see that has increased over time. But blue during pregnancy, depression during pregnancy has increased at a more vertical slope, so a steeper slope. So the number is increasing, and it's increasing more than the depression before pregnancy indicator. And reports of having postpartum depression symptoms has increased a little bit, but is generally stable. And so over here, we've got questions about, is this related to better screening? Is it related to women talking to their providers? Is it because more people are experiencing depression? What is the reason behind this increase? And why are we not seeing the increase in postpartum depression symptoms? So I have theories. I'm sure you have theories. Interesting stuff. Okay. 2 more pieces of data. Let's see how I'm doing on time. I have 1 minute. Okay. So here we've got tobacco use. So you can see 19% of women reported using tobacco before pregnancy, slightly fewer, well, in the past 2 years, then slightly fewer before pregnancy. 59% of smokers quit smoking during pregnancy, and then of that, 40% resumed smoking after pregnancy. These two numbers are higher than the PRAMS national average, and so more women in Nebraska are using cigarettes before, during, and after pregnancy than nationally. We have a disability supplement and that we added in 2018 to 2020, and there's a fact sheet that we created using the data. You can access that here, and I can share that in the chat if that would be helpful. And one of the things that I really like about this supplement is that it includes qualitative data. So the PRAM survey has a place for comments, and we often get a lot of comments about like labor and delivery experiences and just a lot of stress and financial costs and that kind of thing. We get a lot of comments that hit on multiple topics that aren't very easy to separate out. So this quote kind of represents that complexity. As far as conclusions, I have a few slides after this, but PRAMS provides key self-report data on the experience of postpartum birthing people. Our response rate for Black respondents limits the utility of our data for that race and ethnicity group. And then there are topical areas, including depression, anxiety, tobacco use, and chronic disease that indicate the need for future work. So you can access PRAMS materials through our website. We have fact sheets that are designed for healthcare providers, so their reading level is a little bit higher. And then we have general PRAMS materials. We have issue briefs and brochures. We have posters, and we have a resource directory that is available. These are available for the general public. And then we also are always asking people to encourage moms to fill out the survey. So encourage birthing people to fill out the PRAMS survey when you're able. And here's my contact information. Thank you.
Thank you, Jessica. And we'll make sure that we share out folks' information as a follow-up and all of that. Y'all can drop it in the chat as well because there will be a record. So I have a lot of questions that I was jotting down, but our audience also has questions. So I really want to start with them versus some of the things that we already kind of named that we wanted to discuss. And so, Celeste, this was really given during your presentation. If you can share what factors influence the lack of disaggregation despite small numbers. And again, for those that are just joining us, Celeste talked about the Maternal Mortality Review Committee report.
Yeah, so I guess the main issue is when numbers are basically fewer than 10. So if we have fewer than 10 people in a group, it it's kind of challenging because the law states that you can't release data if it's fewer than 10 because for most cases because it can be identifiable. So what we don't want is to have this really detailed information about someone's life and death that can be identifiable back to a particular individual. So we try to balance, releasing as much data as we can with also keeping keeping that information private.
Thank you. Um, and this question is around just in general from the reports. Is there anyone collecting around trauma or harm that is done from someone's experience? And one of my questions, and Celeste, we talk about this a lot. So, IB Black Girl convenes a Black maternal health coalition. It's statewide, and we have community-based partners and traditional institution partners that are there having this conversation around, like, what is the state of Black maternal health in Nebraska? And some of the things that we've talked about and wrestled with in this coalition is around near-death experiences and just like shitty experiences in general. Like, this should have
Mhm.
not happened to me, but I did not die, or this was my experience. For folks that have been following our birth justice work, we had a mom share her birthing story around how she lost her entire reproductive system after a C-section and not being able to give consent, her near death experience and what that means for her now. And so I think this kind of question goes along already with what we have been wrestling with. And so could both of you give insight to how do we get those experiences? How do we do more storytelling? Like, what does that look like for you all? And if there's not anything there too, right? Like, just kind of naming that so we can kind of wrap our arms around it.
I'll go first because I have an easier answer, and Celeste, I think, can get into the juicy good stuff here. So PRAMS doesn't have any quantitative questions about this, so we're not specifically asking about people's birth trauma or medical assault, but we do have that back page where they can leave comments, and people that have intense experiences, traumatic experiences, often do leave comments on there. So we have that data for many years back, but we haven't used it in a systematic way. So we have opportunity, but we also would need clear direction on how to use that, where to go with it.
Thank you. Celeste?
Yeah, so my answer has maybe less to do with this specific idea of medical assault or birth trauma, but what Ashley was more to what Ashley was kind of mentioning with, which is in my world what we call severe maternal morbidity or SMM, which are those near death experiences or severe complications from birth and pregnancy and the like. So in that case, you'll see in my report, no, but really, we do try to address some of that. So the hospital discharge data has specific codes that are related to things like, lots of blood transfusion or hysterectomy or these kind of severe complications that can arise during labor and delivery, particularly. And so we do look at those to see kind of what's affecting the birthing population in Nebraska, but we're looking to do more work with this. So, it would be really great if we were able to dive a lot deeper and kind of see what's affecting more people. So if we think of death as the top of an iceberg, we have all of these injuries and extreme experiences that aren't death, but they're definitely life changing in many cases. And they're more of like what's underneath the water as the iceberg, which is always bigger. And so it would be nice to understand those more and be able to make recommendations.
Yeah. And I mean, and just again, there are a lot of folks that are in this work here, a lot of birthing people that are commenting. I think for us, and when we talk about centering Black birthing people, we know that our experiences are more inequitable, right? Like, we're having
Oh, yeah.
these experiences. And so, like, how do we get traditional hospital institutions to listen, to move, to transform when, according to the data, right, like, we're not dying, and that's what, like, kind of the measurement is? Or so I think, folks are wrestling with that conversation of how is data actually utilized to transform and not weaponized against us. There's an article I put in the chat, and one of the doctors was kind of reviewing the new CDC data, right? So, death cases in the nation increased for Black birthing people. They were talking about what does that look like, maybe the contributing factors. And I thought it was interesting that this doctor said, like, we have all the MMRCs, like, we have all of these things, and like, shit is not changing. It's getting worse. And so, like, none of these things are enough. And what do we do? And I think for the people here and listening, like that's really our call. Like these things exist and we need to partner, we need to understand. And also, what are those next steps so that we can make sure that outside of death, our birthing experience and our just well being in general, right, allows us to thrive and live wholly. So I want to kind of jump to what you just named that's attached to this, and then I'm going to go back to the question. So don't worry, folks, I'm going to get to the questions. But Christian wanted to know for the comments that are on the back pages, is that available through a public record?
I think so. I don't know. I think so. That's my answer right now.
And then maybe we can follow up, put a note to that, and then we can help make sure that if it is, and we can let the folks know. Okay, I'll put a note. And Christian, don't let me forget. Christian is one of our board members and works at March of Dimes. So she is a great resource and partner for us. Okay, so let's get into some more of these questions. This is really around, Jessica, for you, for the data for Black folks, right? Like, again, for us, as we think about centering those most impacted, we don't necessarily have the experience represented in the PRAMS report in the same way as other racial groups and folks with other ethnic identities. So is there an incentive for participants selected to do the survey, or how are you navigating that?
So everyone who completes the PRAM survey gets a $20 reward card to either Walmart or Target. And so that's something that we've had in place since 2019, and it seems to work pretty well for most populations. We are currently working on implementing an initiative to work with Omaha Healthy Start to identify people who have been sampled by PRAMs that are also Omaha Healthy Start participants that would then be contacted by Omaha Healthy Start to kind of raise awareness that they've been selected to participate in PRAMs, and then from there be able to kind of hand deliver the PRAM survey to those participants or potential participants, and then they could send the survey back to us. And we're working with the 4 federally recognized tribes in Nebraska to do that initiative as well. And so right now we're working on implementing it to pilot it, and then if it's successful, we could expand it as needed. And so our intention there was to work with the 2 race ethnicity groups that have the lowest response rate for PRAMs. If we need different incentives, or if we need, if we need something new, I'm all ears. Love to hear about it.
Yeah. And there may be opportunity too. Like I'm thinking about the push for doulas, especially in Black community. Like maybe that's a place, as doulas are supporting some of that postpartum care, to partner with like Omaha Black Doula Association to help with that. So we can definitely follow up. And then it seemed like in the chat. So this is recorded, so folks will be able to access this on our YouTube page. There's other kind of community-based centers where people were interested in helping with that survey and getting some numbers back, so we can make sure we connect you to those folks, Jessica. Okay, so next question. Are there examples, opportunities for community collaboration among the Black population? If there are some states, Christian knows that there are some states that have done other incentives for Native American moms and birthing people. So I know you kind of named some of that through the federally qualified health centers, like a Charles Drew, who does Omaha Healthy Starts. But is there anything else that you can think of that you're seeing across that you're working to implement here that y'all have toyed with?
Not yet. We used to have a member on our steering committee that was the WIC manager at Charles Drew, I believe. No, so for Douglas County Health Department. And so she encouraged us to work specifically with WIC, but we didn't ever get anything really developed. So I'm open. I'm very interested. Love to work on this. So if you have an idea for community collaboration, yes, please, let's talk more.
Okay. And Jessica, these next couple of questions are for you.
Yeah.
So have the experiences of PRAM survey participants been collected, analyzed by HHS? Could adverse experiences during interviews influence declining participation rates?
It could, yes. So we do collect and analyze data. So we have data reports and fact sheets for different topics, including things like maternal mental health and breastfeeding and safe sleep and prenatal care, counseling, topics like that. Could adverse experiences during interviews influence declining participation rates? Yes. So we have a measure that looks at stress during the past 12 months. I think it's 12 months before giving birth. What kind of stressors did you experience? And we separate that out, or we can create 4 different variables from that. So, traumatic stress, financial stress, emotional stress, and partner related stress. But I haven't specifically looked to see if that influences declining participation. That's interesting.
So maybe there's an opportunity there as well.
Mm-hmm. Mm-hmm.
And that it kind of flows into the next question around that the CDC has been having discussions around adding or improving standardized questions about racial discrimination as a part of PRAMs. What is that current status here in Nebraska?
So right now, the CDC is finalizing the new core set of questions that all PRAMS participating states will implement in 2023. And we will get that list in May. And so in May, we will review the list of new core questions that all states have to ask. And then we will have conversations to talk about what else we want to ask. So there's going to be like a standard booklet of questions that you could add to your survey. And so we'll take the core and we'll take the standard set and we'll say these are the 80-ish questions that we want to have on our survey. So that work will be done all summer. And yes, Christian, I want you to be part of it. Anyone who's interested, the more the merrier for giving us input and helping us make sure we have the right questions and the right topics included.
Mm-hmm. Even the incentives, because I don't want to answer 80 questions, in the world of things coming quick, right? Like, so if I'm going to answer 80 questions, what does that incentive really look like?
Oh, yeah. Mm-hmm.
So again, folks can see like I'm adding value and you're respecting my time. So yeah, okay. So then there's just some comments. Keep having the conversations going as folks are in the chat. But I wanted to specifically lift up this conversation around specific recommendations made to providers around equitable medical treatment. So this person named that the number was high for mortality rates with mothers who had public insurance versus private. And we know a majority of births, especially in communities of color, are done on Medicaid. And from their own experience, the level of care and the types of screenings that could be received were drastically different. And so thank you, one, for naming, Shanketta, your experiences and what you navigated. But looking at like the recommendations in general, and I think that's the place where maybe we can talk about broadly as well. Like, again, the data is great. Again, I'm not a data girl in the same way, but like, what do you do with it?
Yeah.
Right? Like, I know that there's a list of recommendations, but what does it truly look like when you implement? Have you all talked about like accountability to those recommendations? Like, who owns it? Like, can you maybe speak to more about kind of that trajectory and ripple effect once you have these recommendations being moved out, and if there is anything around equitable medical treatment?
Sure. So right now, we're in a really cool spot. Unfortunately, it's happening now and not like 5 years ago with our recommendations where we're focusing really intensely on them. So, like I mentioned in my presentation, there's like 100 recommendations that they came up with, but like there's not enough time and people in the world to do that. So, what we really need to do and what we're planning to do in like 2 weeks is sit down as a committee and really look at those recommendations, make them kind of in this like who is doing this, what exactly are they doing, when exactly are they doing it, and kind of creating more actionable recommendations so that we can send them out to the community and say, hey, for example, March of Dimes or Nebraska Perinatal Collaborative, like we know you're already working on this. This came out of the MMRC as a recommendation. Can we partner? It's sort of the same model that like the child death review team or even the fetal and infant mortality review in Douglas County use, where they have recommendations that are really tied back to the community. And that's what we're trying to move forward to do. Right now, we're not quite there, but it's really happening, I mean, in the next couple of months. So I'm looking forward to that because these are the the questions that I've continued to ask as well. And we have these conversations, but we just haven't had the specific time to look at them really deeply, which we're going to be doing soon. So, yeah, I think speaking to this like equitable medical treatment and kind of just generally recommendations for providers and things like that, I would say a person comes into your office, they are a whole being and they have probably, this baggage and that baggage, no matter who they are, they have things going on in their lives that are probably bigger than what you can address in your office at that time. But be aware of them, try to connect to any other places where they could, receive treatment or counseling or, just resources to deal with all of their whole being. That is what would really make a huge difference, just generally speaking, I think. And I know that doesn't really fit into the systems that have been created in this country, but trying to think outside the box and really um, think more holistically is kind of the general idea of what we see.
Mhm. Jessica, did you have a thought on that?
Yeah, just to add to what Celeste is saying, PRAMS doesn't have the capacity to take action from the recommendations from general recommendations. We have the capacity to collect the data, to create data reports, but from there, making change requires partnership and collaboration. And if we don't have that, then it's just data that we're not using.
Yeah. I would add to that, just being transparent. When we think about and like the way in which we approach our work with IB Black Girl, we take a womanist approach. We're taking, an anti-racist approach. And for us, that means we have to think about abolitionist frameworks and what does it mean to work within a system or not. And so
Mhm.
we're always in this place of balance, just being honest of these are the systems that exist, the systems that get the resources, that have the power and influence. So how do we work to transform, to help catalyze, to dismantle, while also thinking about, right, like when you think about the history of these systems, and I always go back to Dr. Deidre Cooper Owens' book around what does it mean for this medical field to be built on the harm and trauma and experimentation of enslaved Black women, right? So, like, it wasn't built for us, never intended for us, and still isn't serving us. So, how do we really catalyze in community? Like, how do we really center the leadership, the solutions of folks that are closest impacted, that have the lived experience to really lead on what does this mean to create a different, total environment? And for us, that's the balance.
Mhm.
So I think from an accountability standpoint, right, like we have to set and right size expectations of what does it look like you said, you don't have the capacity. What does it mean for HHS to own this or not, to be a partner or not? And then what does it mean for other organizations to really step in and say, like, we can hold this because of what we're able to do and the way in which we do it. So I just wanted to name that for us. So that's a place that we continue to balance and go back and forth with. So we are almost at time. I can't believe this hour went by so fast. I want to ask this last question and then we are going to wrap up. My commitment to y'all, and I will give this plug again, is that one, we do trainings and sessions all year round. So this will not be the last time that you see these folks. October is Black Maternal Health Month in Nebraska, and we have amazing lineup that we're building of sessions from a conference perspective and opportunities to continue to intentionally engage. But right, this is a long-term commitment. So this is not the end of this conversation. It won't just happen again in October. We'll continue to create space and help convene partners to work on this. So just know that it doesn't stop after this hour. So I want to move to just the medical side and just offer this question from Dr. Jones around what is the best thing we can recommend for healthcare workers when caring for birthing people of color? Are there flags, prompts that we can recommend in the medical record that can help with implicit bias, et cetera? So thinking about your recommendations, has there been a focus on the practitioners and the healthcare workers, or has that not yet been named?
So, yes, there is a focus. On the MMRC side, there are several kind of key things we look for implicit bias or explicit bias that folks experience when they're working through the systems. So we are identifying those things, and we need some real discussion about how to address what's happening and what real recommendations we can make. But I think just generally, like without putting that aside, just generally thinking about the stuff that Ashley you were just mentioning, like how were these systems built? Who were they built for, and in under what conditions? Keeping that in mind as you treat a person, as you see people, I think that is super important. And just being open to thinking outside the box as well.
Mhm. And right, and like I think this a holistic approach, right? So like how does
Mhm.
policy help codify some of this? So this past session, Senator Kavanaugh introduced a bill that would require medical practitioners that touched a birthing person. So that could be like a dermatologist, a
Yeah.
therapist, right? To receive this training. We know that training does not solve for institutional racism. So I want to say that, but it helps to chip away, right, at some of these things. And it did not pass. And so I think that as we think about how do we comprehensively approach this work, what role do y'all play in the reporting and recommendations, the partnerships that happen? How can policy work to codify what we know to be true and help, right? Like all of those different pieces, I think, go together and would, again, help to see movement happen at the system level. So, okay, we are at time. We're actually a minute over. So, I want to wrap up today and just say thank you again to Celeste and Jessica for coming and helping us better understand the data. For the folks in the chat asking really critical, hard questions, like we had a slate of questions for both of them that I didn't even get to because you all had things that you wanted to ask and get answered, and they were amazing questions. So, thank you for bringing your voice into the room and being with us today. As I mentioned, this is Black Maternal Health Week nationally. So we posted in our newsletter, which is all on our social media, other events that are happening and held by Black Mamas Matter Alliance, who created this week. We also are having on Saturday a community baby shower for Black birthing people. Registration is required for that. So look on our social, we have the registration information. So if you're serving Black birthing people, please send them to register. The baby shower is going to be real cute, tons of giveaways and all the things for us to love on folks. Then we also have a birthing resource fair right after, which is free and open to the public, no registration required. So please check out what we're doing locally this week. And then also stay tuned as we think about what's coming up in the interim between now and October, and then our intentional slate of activities in October. Please stay engaged. Again, thank you both for being here. Thank you for the folks in the chat having great and critical conversation. And like the work continues, right? It's too urgent, it's too important. So we will always continue to work on behalf of and for Black women, femmes, and girls, and especially Black birthing people in this instance. So thank you all. Have a great rest of your day and make sure y'all stay hydrated.
Yes, thank you. Have a good day.